afternoon, everyone, and welcome to our second webinar session. My name is Ingrid, and I'm the Administrative Director at Swiss Medical Guide. For those of you who hasn't been here to participate to the first webinar, I would like just to introduce a little bit our company. Swiss Medical Guide is an international medical center, and we are located in Geneva. We are working exclusively with Swiss leading medical experts and Swiss leading medical institutions. We work mostly with medical travel partners all around the world, from Europe to Asia, we are your contact as a bridge between you, your clients, and the medical institution in Switzerland. We are there from the beginning when you send us your medical demand until the departure of your patient. We take care of everything from A to Z. We work as a medical coordinator for the one of you who knows how it works. We coordinate all the medical service and the administrative formalities for the patient, for the families if they have any requests, any needs. We would like to inform you that this webinar is conducted in English and in Russian. And for the Russian participants, we have a Russian room. And if you wish to join the room, our webmaster, Alexander, will explain this to you right now. Please go ahead, Alexander. Александр.
Уважаемые партнеры, добрый день. Меня зовут Александр, и я являюсь веб-мастером компании Swiss Medical Guide. Сегодня осуществляю техническое сопровождение веб-семинара. Сразу хотелось бы сказать, что если у вас возникают какие-то технические трудности либо неполадки в процессе семинара, вы можете смело писать на WhatsApp. Номер опубликован в чате. Также хочется сказать, что для вашего удобства, то есть для удобства русскоговорящей аудитории, сегодняшний семинар будет переводиться в прямом эфире. Если вы хотите слушать русскую версию, то есть переводчика, вам нужно написать в чат, и я вас переведу в комнату с переводчиком. На этом у меня все. Приятного просмотра.
Does it mean that it's my turn now?
Yes, please.
Thank you. We also would like to inform you that the webinar is recorded. And as per the end of May, normally, we will also have our own channel on YouTube, and everyone will be able to watch it online in their own language of the country if they decide so. Nevertheless, we have two recommendations for you for today. Meanwhile, you are watching this webinar, we ask you, if possible, to switch off your camera, but we definitely ask you to switch off, to put on mute to avoid all noises around. And the doctor will do their speech. If you have any question, please send them via chat. And Dr. Rabaeus, who's doing the link, after the speech of the doctor, he will pass them on and you will have your answer. The medical part will be led by the doctor, and I will leave you now with Dr. Rabaeus, who is our Chief Medical Advisor at Swiss Medical Guide. I wish you a pleasant webinar, and I thank you.
Thank you, Ingrid. So it's my great pleasure to be here again today to preside the new webinar by Swiss Medical Guide. My name is Dr. Michael Rabaeus, and I am the Chief Medical Advisor of Swiss Medical Guide. Our session today is devoted to rheumatology and orthopedic surgery. And we will have the pleasure of listening to two physicians from HOPITAL La Tour in Geneva, which is one of the leading private hospitals in Switzerland. As it is the first time that we are working with them, we thought it was also the right moment to have a presentation of what this hospital looks like. So that's why our webinar today will start with Mr. Mehdi Bensouda, who will present to you the HOPITAL La Tour, and we will then listen to the two physicians. So I switch over the chair to Mr. Bensouda, and I'll see you a little bit later.
Thank you, Doctor. I'm Mehdi Bensouda. I'm the Chief Financial Officer of HOPITAL La Tour and also Head of Business Development. It's really an honor for us to be with you today to present you HOPITAL La Tour, and particularly you will have the chance to listen about our best and leading doctors in our hospital. So HOPITAL La Tour has been founded more than 40 years ago. It is the first private hospital in the French-speaking parts with more than 200 beds, 11 ORs, and we are working with more than 1,200 employees. Our mission is to give access to the best healthcare, to the best healthcare to our community, but also we have this ambition to bring to us international patients so they can have the best treatments. And we want to become a center of excellence particularly in orthopedic, that you will hear a lot about today, cardiac surgery, oncology, but also we want to serve our local community with intensive care units and emergency units. And this is basically our key strengths today compared to other private hospitals in the region. We have emergency units working 24 hours and 7/7. We are working very closely with the Swiss Olympic Center, and we are certified. And this is part of our pathway in orthopedic. Many of our patients, after having orthopedic surgery, will go through a rehabilitation center with the best sports medicine. And the last but not least, we have intensive care units and continuing care units. I think this, with the HOPITAL, with the other hospital in Geneva, we had the other center, we have this capability, and this helped us a lot during this COVID circumstances, where we were able to treat many patients through our emergencies and through our intensive care units. So this is the spectrum of all the specialties that we have. I think this is one of the reasons why patients are coming to us, because they know if they have any particular disease, they can be treated. And also one of the strengths of our campus is the strong collaboration between the different medical doctors who collaborate very, very well. For example, in orthopedic, between physiotherapy, sport medicines, and orthopedic, they work hand in hand across the care pathway, focusing on quality of care and safety. So as I said, we have one of the biggest number of operating room in the private facility in the French-speaking part, and we have invested more than 150 million in the last 2 years to upgrade and to extend our facility. And here I will just show you briefly few pictures to show you this very beautiful and facility here in Geneva. One of the key strengths as well is we are situated very closely to the airport. We are 3 or 4 kilometers to the airport, and of course, from Geneva, as you know, you can have access to the Swiss Alps. So this is, as you can see, it's a high-end hospital, but there is a very strong focus around patient experience and services that we want to offer. Here is the sport medicine with a close collaboration with the Swiss Olympic. We have many athletes, famous athletes coming to our facility to get treated. And I think for us, it's really an honor to serve those patients. This is the rehab center with the swimming pool. This is the sports medicines where the rehabilitation is performed once, for example, a patient had orthopedic surgery. the cryotherapy. And one of the other strengths that we have, as I said, invested a lot the last couple of months in the latest technologies in imaging, with the latest scanner, ultrasound, radiotherapy for oncology. So as you can see, 3 MRIs, Da Vinci robotics. So this is really one of our key priorities, always to provide the doctors with the best technology and infrastructure. This is our rooms. As you can see, it's high-end rooms where the patient is very well treated. And yeah, and that's it for me at this stage. And of course, if you want to learn more about the hospital, we'll be more than happy to organize something for you. And we are here to serve all your demand. I will pass now.
I will take over.
Yeah.
Again, thank you very much, Mr. Bensouda, for showing us what it looks like. I can only underline the high quality associated with HOPITAL Latour, in which I did work actually many years ago. And that's one of the main reasons why we have chosen to collaborate also with HOPITAL Latour. So we will now go to the medical part of our webinar. First, Dr. Christofilopoulos, an orthopedic surgeon, very renowned here around, is going to tell us all about hip replacement, hip prosthesis. And it's my great pleasure to turn over the chair to him. Your turn.
Good morning, everybody. I hope my presentation is on. As Dr. Rabaeus mentioned, even though I'm an orthopedic surgeon, I will only talk about hips. And this is one of the particularities of HOPITAL de Latour, is that orthopedic surgeons here deal with one joint each. We're not all around orthopedic surgeons. We're highly specialized, each one of us in his own domain. So hip arthroplasty, a pathway to success. You have to know that hip arthroplasty represents today 2% of all surgical interventions done worldwide. There's more than 1 million of them done per year, 100,000 in France, about 10,000 in Switzerland, and it is increasing about 2% a year. Now, not only the number of cases increases, but also patients' expectations, since these surgeries today, if done correctly, should last about 20 to 25 years. The results in patients above 75 years of age are very promising. We can talk to these patients about having one surgery in a lifetime. That's not the same for young patients, because they will use their joints much more than elderly patients, doing activities that were once forbidden with a hip arthroplasty, but are today activities that patients ask for. What are the indications today in hip arthroplasty? The indications have changed. We don't talk anymore about older age as being an indication. We talk about pain, loss of muscle and function, stiffness, diminishing quality of life, an X-ray, of course, with signs of arthritis and fractures around the hip. How do we judge whether a patient needs a hip arthroplasty or not? Well, we don't. It's the patient who decides. We will propose it if his hip scores, so his quality of life related to hip pathology scores, show a bad result. But we are not the ones deciding. It's our patient who decides. Now, the challenges in a surgery that is so well performing are to avoid complications. Common complications with hip arthroplasty, you've heard of them: leg length discrepancy, dislocations, fractures, infections, and other systemic complications. The methods we use today to perform hip arthroplasty are either with cemented or uncemented implants. Friction couples may vary. Custom-made implants are more and more used in younger patients. Minimally invasive approaches, robots, navigation, etc. The whole point of that is, as I stated before, provide a long-term success. These are the different wear characteristics of different types of prostheses we use. You have to know that metal on metal has not been used for the last 15 years here at Latour. Now, considering approaches, there are a bunch of classic approaches, as you see on the left, and interpretations into in hyphen minimally invasive surgery on the right. But minimally invasive surgery doesn't mean a small incision. It means that you don't do damage to the structures beneath the skin. Typical approaches for hip arthroplasty are posterior, lateral, and today in Switzerland, direct anterior. Each one of them has advantages and disadvantages, but I would say that the one that will be used the most in the future because of its clear advantages in hip surgery is anterior approach. What is the advantage? It offers an excellent exposure to the hip joint, it's fast, there's a low dislocation rate, it's muscle sparing and permits fast recovery. But then why doesn't everybody use it? Well, simply because it's difficult. There's a steep learning curve, and if the surgeon you're seeing is not a specialist in this domain, he should be avoiding it. When we compare a gait analysis on how people walk after hip arthroplasty, there are clear advantages to be shown for this method. When we compare how much money is spent per case, there are clear advantages when you compare anterior approach to the other approaches, meaning that you have less hospital costs, less hospitalization days, less intra-hospital sessions of physiotherapy, fewer patients needing rehabilitation centers, and a shorter operative time per case. When we compare the damage that you do to the body, to the muscles between approaches, again, anterior arthroplasty, when done correctly, causes significantly less damage. To summarize all of these studies that have been going on in the last, I would say, 10 years, my team wrote an article in a very renowned journal, which is an open access journal. You have access to it freely, stating the pros and cons of anterior hip arthroplasty. There's another article in French that has been written back in 2010 that was already showing the promising results of our method. Now, why Latour? Because there's a clear clinical pathway and because total hip arthroplasty is a routine surgery. There are 3 surgeons performing hip arthroplasties at Latour, myself and 2 of my highly specialized colleagues. The clinical pathway consists of an appointment with one of us, a preoperative course if you decide to have surgery. You're going to have quick surgery, you're going to be mobilized immediately, go back home fast. You're going to have a correct follow-up for your wound and stitch removal, the physiotherapy you need, and you're going to have, very important, a follow-up. We will not just do the surgery and say goodbye. The appointment is organized in a way to have everything done in a short period of time and at the same area, meaning that our offices are situated exactly where the radiology suite is, where the surgery suite is, and where the patient's rooms are. So you'll have your x-ray, your scores taken, your physical exam. We will explain the surgery if you need one and fix directly your operative date together with a quick resume for your general practitioner. You will be entering, if you wish to, the hospital on the same day of surgery, meaning that you don't need to spend nights and money before surgery. You will be entering a dedicated ward where only orthopedic surgery is done. This diminishes the stress of seeing other patients with different diseases. It diminishes the workload of our teams and diminishes the costs. The intervention is something that is done in a very precise way, a little bit like a Swiss watch. There are dedicated teams, dedicated rooms, which means that we have less infections because there is no digestive or any other type of dirty surgery done in the same room. We diminish anesthetic complications, the workload of everybody, and there are, in this way, less errors. A patient receiving a total hip arthroplasty will be mobilized some hours after surgery. There's a dedicated physiotherapy team who will do that. This diminishes any form of systemic complications like pulmonary embolisms and thrombotic episodes. This means that you're going to need less physiotherapy and you're going to diminish again the costs. Less infections, less hospital stay. This is going to cost less money for your clients. Considering the wound that After your surgery, you will have a special machine. That means that you don't have to change the dressing every second day as with conventional methods. The dressing is changed once before you leave the hospital and once before you remove the stitches. It is done by dedicated nurses in dedicated spaces, and this diminishes wound infection complications. Physiotherapy, if you wish to undertake it at Hôpital de la Tour, consists of both hydrotherapy very quickly after surgery, with classes done to patients having hip arthroplasty together, which means that there is a clear emulation between patients. If you need further physiotherapy in our sports center, you will of course have the possibility to book it. Short-term follow-up is very important, 1 month post-surgery to take an x-ray, see whether the patient needs more physiotherapy, and make sure you find an objective way of seeing whether the patient is happy or not. And this is done with PROMs, so scores relating patient's opinion about his outcomes. After that, the patient is seen again 6 months after surgery, a year after surgery, 5 years after surgery, etc., etc. If the patient doesn't wish to come back to Switzerland or simply cannot come back, we strongly advise him or her to send us his x-rays in order to make sure that everything is going okay with his implant, and hence avoiding disasters and proving the high quality of care that we are giving you. Some numbers to stop here because I'm gonna take too much time. We do about 350 total hip arthroplasties per year here at La Tour. It's a surgery, since it's routine, that takes a very short time. Most of us do it in under 40 minutes. The mean hospital stay for our patients is 3 to 4 days. We have 0% infections the last 2 years, knowing that the mean national rate of infections in Switzerland is around 1.5%. 0.3% dislocations, which is a very low number, and we rarely transfuse our patients. Thank you for your attention.
Thank you very, very much, Dr. Christofilopoulos. That was really interesting, and I think personally I learned something also about the anterior approach, and I think it's very important. And what I would like to underline is how this new way of doing it, which takes more time to learn, is actually in the patient's interest, and that's something that is for Swiss Medical Gate extremely important.
Thank you.
Apparently there are no questions for the moment. I see nothing on my WhatsApp and nothing on the converse. No, so
I think we see some questions in Russian, I think.
Yeah, no, but normally they should be translated for me, and I don't see anything having been done. Okay, so then we can move to the second presentation by Dr. Fleury, a rheumatologist, specialized and also working in l'Hôpital La Tour, who will give us a nice overview of what we understand by rheumatology and what can be done, and what are the important factors of the future. So, Dr. Fleury, I'll leave the word to you.
Thank you. So I hope that my presentation is on. So good afternoon. My name is Gregory Fleury. I'm going to speak about hip osteoarthritis. First of all, few words about me. I began my medical career. Sorry, I cannot change. Thank you. In internal medicine, that I finished before beginning rheumatology in the University Hospital of Geneva. In parallel, I did a specific formation on osteoarticular ultrasonography. Currently, I'm working in La Tour Hospital since 2017, and I'm working also in the University Hospital of Geneva, where I teach ultrasonography and also rheumatology. I'm also president of the Geneva Rheumatology Group since 2019, where I represent my colleague in different committees. So what is rheumatology? Rheumatology cares about osteoarticular problems due to mechanical or degenerative disease like osteoarthritis or tendinopathies. The rheumatology care also inflammatory and autoimmune disease like rheumatoid arthritis, panayiotis, conjunctivitis like lupus, Sjogren disease, myositis, vasculitis, and microcrystalline arthropathies like gout or chondrocalcinosis. For that, we can use human immunosuppressive therapies like biotherapies. Ultrasonography is a non-irradiant technique producing images, permitting doing diagnosis by themselves or by the intermediary of the analysis of the liquid, functioning and emptying, articulation, alleviate the pain. Doing that by ultrasonography creates less pain due to the direct way of the syringe to the target and permit also a great accuracy during infiltration. The left images that you can see here show a needle inside an articulation, and the white cloud here is cortisone. We, in the right images here, shows fluid inside articulation called synovitis. It permits to diagnose and assess the severity of some autoimmune disease like rheumatoid arthritis. La Tour Hospital assembled almost all specialties in the same building, facilitating interaction and sharing information. For me, as rheumatologist, I can discuss by phone, by email, directly with specific specialists like radiologists specialized in osteoarticular disease or orthopedic surgeons caring for hip, shoulder, knee, foot, and back. I have also interaction with sports medicine specialists, physiotherapists, permitting complete care with a great followings. Today we discuss specifically about hip osteoarthritis. That is a frequent pathology treated by rheumatologists, and this disease represents an important part of my daily practice. Hip osteoarthritis touches 25% of the general population, and there is a risk of 10% of risk, prosthesis risk, sorry. The mechanical problem, this decreased mobility capacities leading to an increasing cardiovascular morbidity and mortality. And the rheumatologists perform a conservative approach, trying to control symptoms before in case of contraindication to surgery. Conservative approach try to control fluid growing inside the articulation because it causes pain and decrease the articular mobility. We try to maintain movement and to avoid muscular weakness and leading occasionally to fall and create bad prognosis. For the next slide, I do a really brief summary of conservative treatments according to different medical society carrying osteoarthritis like ACR, American College of Rheumatology, ORC, and EULAR, Humanitarian League Against Rheumatism. I decided not to speak in details about potential future therapies now, like tanezumab, an anti-nerve growth factor, or the sprifermin, which is a cartilage growth factor, or stem cell therapies. First of all, treating and caring osteoarthritis need a multidisciplinary approach and to ensure good compliance. General education and must be provided to the patient. The practitioner must give explanation about osteoarthritis, like what it is and how to deal with it. We have to speak about the risk factor and like trauma and overweight. This is the first step, then targeted active physiotherapy is essential and we can be performed in individual cabin or in the swimming pool like Dr. Christofilopoulos said. Our team of physiotherapists is very skilled for that approach. The next step is to use drugs. Very often, painkiller, according to the international guidelines and the WHO ladder, paracetamol, anti-inflammatory drugs, and tramadol, and eventually morphines. We can also use intra-articular medication, which is injected with ultrasonography guidance. Steroid is a recommended treatment and can be used up 3 or 4 times in a year. Hyaluronic acid has also a certain efficacy, but until now is not recommended by international guidelines like ACR recently published due to the heterogeneity of the studies. Plasma-rich plaquette, called PRP, is not routinely used for the same reason. Unfortunately, all of these types of medication have no preventive action on cartilage. Cartilage degeneration is sometimes unavailable like familial osteopathies, and the role of the rheumatologist is to support the patient with a conservative approach, essentially with painkiller, and to delay the surgical approach. In summary, according to the international guidelines recently published for conservative treatment of hip osteoarthritis, we begin with active physiotherapy, teaching self-exercise with a goal of muscular reinforcement and better articular mobility. Painkillers, according to the WHO ladder, are used to control the pain and permit movements. Intra-articular medication like steroid under ultrasonography guidance are used for the same reason with a good efficacy and can be done up 3 or 4 per year before the surgery or in case of contraindication of it. Latour Hospital is therefore perfectly able to bring all of this, the multidisciplinary approach to the patient, because all specialists are skilled for this pathology and giving him or her the best chances to receive the best treatment. Thank you.
Thank you very much, Dr. Fleury. And I learned quite a lot again. That's very interesting, these webinars. I do see that we have a question from Irina. I don't know the family name. I'm sorry to be familiar like this, Irina. She asks a question about Bechterew disease, whether there are any new medicines or technology more than, for example, Cosentyx. Tridatayan was the name of Irina.
Okay, the question is...
Is there anything new for Bechterew disease?
The new for Bechterew disease. So to treat Bechterew disease, we have anti-inflammatory drugs in the first step, and depending of the reaction and the evolution and the response of the therapies, we can add to this, depending of the Bechterew disease is only axial or perifocal one, we can add methotrexate for the perifocal activity, and if there is axial activity like with Romanus lesion or spondyloarthritis or sacroiliitis, we can use anti-TNF-alpha or anti-IL-17 like secukinumab. And for the anti-TNF-alpha, there are many that you can use depending of comorbidity and interval of halfway of administration. And for now, this is the two main biotherapies that you can use in spondyloarthritis.
But they are here already for some time, or is there anything new which is being tested presently?
Now, if there is new, I don't know, but for that we can use, there is these two.
Okay.
For Bechterew disease.
Does anybody else have any questions?
Dr. Rabaeus, we have a questions from Galaxy R4050. What what methods do you use? I missed. If yes, what could you say about ill technique, advantages and disadvantages? Thank you.
I guess this question is for me. So
I don't know if yes, it's for Dr. Christofilopoulos.
Yeah. So the approach, you can call it whatever you want. Since it's a direct anterior approach, you can call it AMIS, DAMIS, ASIS, Yale, or whatever. It's the same approach. It's an approach going through the interval of the anterior muscles of the hip. So everybody has the particularity of doing it with a separate jig or tool or whatever, and will find advantages for his method or the other. I would say that there are clear advantages of all anterior approaches, as I stated in my article last year, and calling them with different names, that's marketing. That's not science.
But I think it was interesting, your presentation on all this, because it really makes it clear that this approach is something which should be preferred, especially for foreign patients, that if they can spend less time and less money, it's clearly an advantage. Any other questions?
I think I have a question that I've received directly on my phone, but it's in French. It's for Dr. Fleury, and I don't want to make any mistake. Let me just double check. One of my friends has pain in her hands, and she's wondering what would you recommend? I'm sorry if I make any mistake with the English word, so I'll tell you in French, Dr. Fleury, and then we go ahead. It's infiltration, acid, or cortisone. What would you recommend?
Depending of the comorbidities, but specific on osteoarthritis, the recommended treatment is cortisone, not hyaluronic acid. The effect of hyaluronic acid has been the better efficacy is for knee. The only positive study that we have is for knee. We don't know exactly for hands, but for sure it depends of the comorbidities, if there is a cardiac failure, diabetes, kidney problem. So all of this it's important to choose the best treatment, but what is recommended is a steroid.
Thank you, Dr. Fleury.
Okay, I see there is also a question from the Russian room. If you have a medical history in Russia, you need to take it with you. It's something that I will answer then directly, because it's the functioning of Swiss Medical Gate. And the answer is definitely yes, if it is possible, because to have the complete history of what has been done, what has been examined, etc., and what are the different tests that have been done are extremely important when you have to reassess a patient. Whether it is the same disease or a new one, it's important to have all the details of the medical history. So yes, we do appreciate totally to have the complete medical history of all our patients. So, any other questions? Apparently not.
Just concerning, do you have a new medicine technology for back diseases?
Oh, that's what we already talked about.
It's already talked. Okay. Yeah. I don't have. Okay.
So.
Ingrid?
Yes, I'm here. I was just waiting for Dr. Rabaeus to finish before.
Well, then I can, indeed, that's what I was going to do. This was a great pleasure. I personally feel that I learned a few things that I didn't know, really. So I'm happy about that. And thank you all for attending our webinar. And I'm looking forward to see you next week, which will be a webinar devoted to cardiology, and particularly prevention and surgery. So Looking forward to seeing you next week. До свидания.
Thank you, Dr. Rabaeus. Well, my turn to say thank you to everyone. Thank you to the doctors. Thank you to Mr. Mehdi Bensouda. Thank you for all the participants that's been here with us today during the webinar. And as Dr. Rabaeus said, we would like to invite you again next week on the 28th. The hours will be confirmed. I think it's around lunchtime, our time, but you will receive the invitation. It will be about cardiology. Dr. Rabaeus himself will be talking, and as well as an eminent professor from the University Hospital of Geneva, if I'm not wrong. I would like to pass on the words to Marina for our Russian partners that she will end up our webinar, and we'll stay in contact, and we'll thank you once again for your attention.
Дорогие друзья, партнеры, thank you very much. Merci beaucoup à tout le monde. Thank you for everybody. Спасибо большое за ваше участие. Мы вас с удовольствием приглашаем на следующий наш вебинар, который будет 28 мая. Он будет посвящен кардиологии. Это будет очень интересная тема. Если у вас будут дополнительные вопросы к HOPITAL de la Tour, мы, думаю, будем организовывать в октябре, как я уже говорила, семинар, надеюсь, в Швейцарии. И тогда вы сможете встретиться с господином Бенсуда и другими врачами, не только с теми, которые выступали. Thank you very much again, everybody. Thank you, Mr. Bensouda. Thank you, doctors. It was very interesting.
Thank you.
Yeah, thank you. Thank you. Bye.
Merci tout le monde.
Merci.
Bye,
You.
thank you.
Bye-bye.
Okay. Donc on quitte.
Ouais.